Free,
Can you hear me
uh,
clearly?
yes, you open the permit. I find.
Okay, so we will start with the case from the retroperitoneum.
Hôm nay thì em có hai ca muốn trao đổi với giáo sư ạ. Ca thứ nhất là mọi người đã nhìn thấy slide của em chưa ạ? Nhìn thấy slide chưa? Thái nhìn được slide chưa hả? À,
Mọi người nhìn được rồi em à.
vâng ạ. Dạ. Thế ca thứ nhất là bệnh nhân nam 41 tuổi, tiền sử lao phổi đã điều trị 20 năm trước đây. Biểu hiện thì cách đây 2 tháng có chướng bụng, ra mồ hôi trộm, gầy sút cân, khoảng 10 kg trên 3 tháng. Thì, bệnh siêu âm và chụp cắt lớp vi tính thì là hình ảnh các khối tổn thương dọc động mạch chủ bụng, động mạch thận và mạch treo, kích thước lớn nhất là 115 x 183 cm. Cái bệnh phẩm này là sinh thiết ở sau phúc mạc ấy ạ. Cái khối dọc động mạch chủ bụng ấy, thì cái mảnh sinh thiết lõi này được mảnh tương đối dài, thì cấu trúc của các tế bào u là những cái tế bào khá là nhỏ, đứng cái sự kết dính tế bào thì kém, và đứng trên một cái nền nền xơ, cái nền xơ, và cái thành đặc biệt là những cái tế bào có những cái ổ hoại tử nhỏ thôi. Nhìn chung thì các tế bào này khá là nhỏ, nhân tròn, tăng kiểm tính. Hạt nhân thì không rõ ràng, là có những tế bào nhìn thì giống như là nhân nó hơi lệch một phía, bào tương hơi ánh toan một chút. Thì, có là hình ảnh nhân chia nữa. Thì đây cái trên tạo thành những cái ổ nằm trong cái vách xơ này. Đây là cái hình thái mà chụp zoom to lên thì cũng thấy là có những cái ổ hoại tử nhỏ này, với ăn tế bào thì nhân nó kiếm tính tròn rõ, không có cái hạt nhân gì cả. Một số thì bào tương cũng hẹp thôi, nhưng còn một số thì bà nhân thì hơi lệch một phía. Mới đầu thì trong cái trường hợp này ấy, thì những tế bào hình thái như này thì mình xác định là hình thái tế bào u, tế bào nhỏ, tế bào xanh tròn nhỏ, thì cũng là một nhóm đấy cả thôi. Thì có mấy cái chuẩn đoán mình cần cần phân biệt ở đây. Thì đầu tiên là nghĩ đến là u thần kinh nội tiết, là các bác sĩ ở khoa giải phẫu bệnh của em thì nghĩ đến u tế bào thần kinh nội tiết, tế bào nhỏ ấy. Nhưng mà cái vị trí thì nó lại không phù hợp. Bệnh nhân thì tuổi thì cũng thể phù hợp, nhưng mà vị trí cái u dọc động mạch chủ sang phúc mạc thì em nghĩ là cũng không phù hợp lắm. Cái thứ hai là u lanh phô, cũng có thể một cái hướng là u lanh phô. Thì thì bọn em cũng đã làm mấy cái marker về thần kinh nội tiết với u lanh phô, đều âm tính hết. Tiếp theo thì còn một cái nhóm nữa thì em lại nghĩ đến là u tương bào CD, thì em lượng CD138 cũng âm tính. Một cái nhóm nữa là u sarcom màng hoạt dịch ấy, tế bào nó cũng nhỏ, đơn pha, thì em cũng nhuộm âm tính. Một cái nữa là nhóm về cái nguyên bào thần kinh thì em cũng nhuộm với cả S100 cũng âm tính. Và admin là nhóm sarcom cầu vân dạng tế bào nhỏ ấy, thì nhà em thì là hiện tại em nhuộm với admin thì cũng âm tính, và FMA em chưa nhuộm. Thế thế xong tất cả các marker này âm tính thì em cũng có tham khảo chỗ anh Lánh, thì hướng đến một cái nhóm tế bào mầm, còn lại là nhóm tế bào mầm. Thì em cũng giao tiếp một nhuộm với những cái marker nhà em có là CD30, alpha FB, CD117. Em cũng cho nhuộm lại IMA và cam 5.2 để xem có vẻ là của biểu môi không. Thì IMA cam 5.2 đều âm tính, CD30 âm tính, alpha FB cũng âm tính. Thế nên trong trường hợp này chỉ có mỗi cái Q67 thì trên 30 tầm 30%, nên chỉ có CD117 dương tính thôi. Thì cái chuẩn đoán cái ca này ờ, thì là cái u tế bào mầm. Để em bây giờ mình xem là liệu là u tế bào mầm này thì nó sẽ là thuộc nhóm nào của u tế bào mầm đối với bệnh nhân nam giới 41 tuổi. Thì sau đó thì em có trao đổi với trên lâm sàng, thì kiểm tra xem là liệu tinh hoàn của bệnh nhân có vấn đề gì không. Vì trước đấy người ta khám thì chụp siêu âm ổ bụng thì đọc mỗi cái hình ảnh là có tổn thương dọc động mạch chủ bụng với động mạch thận với mạch treo. Thế tuy nhiên là sau khi mà lâm sàng khám kiểm tra thì bệnh nhân này chỉ có một cái bên tinh hoàn bên phải, cái tinh hoàn bên trái thì không có. Thế trong trường hợp này thì như vậy một cái chuẩn đoán là ung tế bào mầm nó hướng đến cái cái seminome của tinh
Rồi
hoàn,
ạ, vậy đó.
hoặc
Ừ.
đấy là
Ừ.
gặp nhiều hơn cả nam giới. Thì yes.
Vậy đó, cái có nó. Mình
À, em đã trình bày xong cái ca thứ nhất thì bây giờ xin ý kiến của giáo sư với chị Hân với cả các bạn ở trong nhóm ạ. Yes, Professor.
Yes, very good discussion.
Yes,
And
that's
I think the differential you've given is very, very good. Um, I think in general, my philosophy for immunohistochemical staining is wherever possible, it's nice to have um, the diagnosis confirmed by at least one positive and one pertinent negative, and if possible, by two stains that are positive, one a nuclear marker or another a cytoplasmic marker, because that gives you greater specificity. But for this sort of a case, there's not a good nuclear marker for seminoma or germ cell tumors generally. So having a solid cytoplasmic marker is very helpful. And then you look for one that's most specific. CD117 is not the most specific marker. As we know, we use it for GI stromal tumors, we use it for some lymphomas and so forth, and other tumors as well at times. But in this setting, considering a germ cell tumor in your differential and the other things in the differential that you have shown, it's fairly specific. The negative markers with AFP or other markers are not particularly, they're supportive. I probably in my laboratory would also do a more specific germ cell marker like PLAP or something like that in our setting. But I think given the information that you have explained and the staining pattern that you have, I think we have pretty well excluded most of the other entities that we should consider. And we have got a good positive stain consistent with your diagnosis of metastatic seminoma involving retroperitoneal tissues. Presuming that the serum markers are also supportive, i.e., there's no AFP or HCG or anything like that that's also present to suggest other elements, then I think we could go forward with treatment based on that. If there was any serologic marker, that would be good to know. You could follow that as a tumor marker, but also that would help to inform future treatment as well. So I think that's a very a good discussion. I did prepare a couple of slides just for comparison's sake for some of the things that we might think of as well. And let me see if I can pull that up here. Just to look at some comparison slides for other things that we would want to look at. So let's go here to this, and we'll go here to here. And then I'll share this screen. Because you showed the differential in terms of in terms of markers, but I think it's also nice to look at what the morphology for some of those other things might look like. So I pulled together a couple of slides. So this, what would we expect with diffuse small round cell tumor As we know, this has several fusion transcript options. Usually EWSR1 with WT1, and it has some overlap with these other lesions, but usually the N-terminal end of WT1, some muscle markers, some keratin that's very dot-like, and that's an important consideration. This is very much like what we tend to see with Merkel cell tumors. It has a dot-like keratin pattern. But it can have several different morphologies. I pulled one representative digital slide to show what that might look like. This is from an intra-abdominal tumor. And you can see at low magnification, it's very desmoplastic, very sclerotic. And you get that to a degree with some germ cell tumors at times, but usually more the cellular cell component rather than the sclerosing component. But as we come in on higher magnification on this, I think you can see there's a fair bit of similarity to some of the cell features we saw in the seminoma. There's kind of pale, wispy, pinkish, slightly cleared cytoplasm. There is generally, rounded nuclei that have packeting effect. They're not highly pleomorphic. We don't have the karyopexis or the nuclear debris that you get with germ cell tumors, but that can be variable at times as well. So I thought that was one nice thing to consider to see one of these, because this is an uncommon tumor, but when it does present, it can be certainly very aggressive and has obviously very different therapy than the germ cell tumors that we would think of. Another lesion to consider in this location would be rhabdomyosarcoma. Now, of course, this is far more common in children than adults, but there are adult cases. Note there are so many syndromes that can be associated with rhabdomyosarcoma. I almost ran out of space to list them all here. And again, this can have Desmond positivity like the diffuse small round cell tumor, MYN positive also, but tends to have other more muscle-specific markers. And here's a nice example that is, as you can see, near the kidney, but has a fairly solid pattern. But on higher magnification, we get into very packeted appearance with, again, quite a bit of kind of pale, clear, wispy cytoplasm that you can see. So we're getting a little Okay. All right, so I tried to mute some of those words. Dr. Doe, can you mute? Okay, very good. All right. But here, we have more pleomorphism, a little more tendency towards sort of strap cells. It looks more mesenchymal, even though in some areas it can be somewhat more packeted or rounded. And then you should see occasionally some of the more myogenic type cytoplasm in some of these lesions. And I'll give you the link to these slides so that you can prepare as well and study them more on your own. The other considerations, maybe not so much. Well, here's what a MyoD1 stain looks like. Not sure this is from this case, but it is a nuclear stain, so it's very helpful in that regard. Lymphomas, as you mentioned, they're in the differential, pretty clear immunohistochemistry with that. But there are some B-cell lymphomas that can give you a lot of sclerosis in the mediastinum and sometimes in the retroperitoneum that can be quite confusing in some settings. Then adrenocortical lesions, sometimes also, let's see. the B cell lymphoma. This is the lymphoma. Adrenocortical tumor. We're still getting some feedback here. So these adrenocortical lesions can have fairly abundant cytoplasm, sometimes be clear. And have a little degree, a variable degree of packeting. And you see here some nesting, but they wouldn't have the fibrous bands usually between groups of cells unless they'd already spread into the retroperitoneum. And then I think finally, it would consider Ewing's. Again, this is more common in a pediatric age group, usually in bone, but extraosseous in some adult cases can occur. And again, there's a EWSR fusion involved here. So if we just do a FISH test for EWSR, we might have some crossover on the molecular testing with Ewing sarcoma, depending on the probe that we use. And here's a nice example of what this looks like in a non-osseous site. Sorry, it's taking so long to load. Well, I may have to just let you look at that later. Neuroblastoma, again, very uncommon in adults, but can have some overlap features with these lesions. And usually this is presenting in a periadrenal or an adrenal location, and the immunohistochemistry would be somewhat different. But the morphology, I think you can usually tell this is a really aggressive high-grade small blue cell tumor. But certainly as we get towards adults, the foci of neuroblastoma may become fewer and further between, and you may start to see areas with more cytoplasm. But these generally have a very high NC ratio compared to seminoma or compared to desmoplastic small round cell tumor, much higher NC ratio in this lesion. And because this is a pediatric lesion, I usually don't sign these out. If I were to see one, I would bring it to my pediatric pathology colleague, Dr. Yu or Dr. Chan, and share with them to get their help on that issue as well. Some of you may remember Dr. Parham, who came with me to Vietnam, probably 10 years ago, I guess, more than 10 years ago, who was particularly adept at these cases and was a great consultant. So then just coming back to compare to what seminoma looks like in a lymph node, and just for reference compared to these others, I think you can see here the same features that we saw on our needle biopsy, wispy pale cytoplasm, round nuclei. Here's a little bit more prominent nucleoli. But note here again that we don't have that sprinkling of lymphocytes that we would expect to see in a primary tumor in the testis. So there's hardly any lymphocytes here, but we do get the karyorrhexis and the round nuclei, the mitotic activity, and so forth. Okay, well, any questions or thoughts on those cases, those slides? If not, I'm going to turn it back to you, Dr. Lin, to present the second case.
Thank you, Professor. You have present now a lot of small cell tumor, a big group tumor, and difficult
Yeah.
group tumor, or different diagnosis. Yes. Chị Hân ơi, ca này chị có ý kiến gì không chị Hân? Em
Uh,
cũng đã
yeah.
HIV âm tính.
Um, I I agree with the professor. Also, it is very exciting case, and Dr. Ling has did a very so excellent diagnosis because she excludes all the other common small round blue cell tumor there, and I think that the clinician clin clinical imaging is very important for us to diagnose it in every situation, and in this case, it helped much for us to confirm the diagnosis. And I think that I totally agree with her. But if she do another more marker like PRIP or OCT34, I think it's if it is positive, I think it's the and CD30 CD30 to
Yeah.
exclude the embryonal carcinoma. Is
Yeah,
then
that's a
I
good
think
point. Yeah,
yes,
that's a
yes. Then I think that we will very happy with the diagnosis, and we hope the patient will pay pay well in treatment. Thank you.
yeah. One of the things I think we discussed last month was that, or I've done it someplace. I thought it was here, but embryonal carcinoma isn't the differential, but usually that really has more of a carcinomatous, almost adenocarcinoma-like appearance, and tends to have much higher grade of nuclear pleomorphism than seminoma. And so I often find that you can distinguish the two morphologically rather than needing strictly immunohistochemistry.
Yes,
If you know you're dealing with a germ cell tumor in the
yes,
testis, and so for example,
yes,
the immunohistochemistry is not going to make a huge difference.
yes.
But in this location, both would be prudent.
Yeah, thank you, Professor.
Dr. Lin, do you want to present the next case, or do you want me to show the slides that you sent me?
That's wait some minutes.
Okay, yeah, we have time.
I will share the second case, tumor in the lung. Ờ, Thế là em có ca thứ hai, thực ra là cái ca này ờ, về ung thư phổi, bệnh nhân nam 41 tuổi, sinh thiết ở phế quản ạ. Thì chẩn đoán trên cái tiêu bản mô vệ học thông thường thì chẩn đoán là ung thư biểu mô không tế bào nhỏ. Tuy nhiên em làm hóa môn miễn dịch thì thấy rằng là cái kiểu hình miễn dịch của nó có sự chồng lấn giữa cả tiếp vẩy và tiếp tuyến. Thế là TTF1 cũng dương tính trung bình lan tỏa, Nasina thì dương tính yếu thì ổ ít hơn là TTF1, còn B63 thì dương tính mạnh lan tỏa, IgA 3 cộng, CK7 và CK5 cũng em cũng làm thêm rồi, cũng dương tính mạnh lan tỏa trên cái mẫu tế bào u này. Thì bây giờ em cũng vẫn cân nhắc không biết để tiếp tuyến hay tiếp vẩy. Có một cái loại mình chia nhỏ là ung thư biểu mô tuyến vẩy ấy, thì nó phải gồm hai thành phần vừa tuyến vừa vẩy, nhưng đây là nó là biểu hiện kiểu hình hóa môn miễn dịch, gọi là song hành của hai loại này, nên là em vẫn lăn tăn chưa biết để phân tích dưới thấp hơn là tuyến hay vẩy. Và đây là cái ca sinh thiết bấm niêm mạc phế quản. Trên một số cái lát mình vẫn thấy cái niêm mạc phế quản bình thường đây. Thế còn khối u thì lan tỏa ở phía dưới đất niêm mạc. Thì cái tế bào u thì có đặc điểm là sắp xếp thành những cái dải, những đám nhỏ, ờ, những đại đây những đám nhỏ gần như là dạng đặc ấy, thì nằm dưới cái niêm mạc của phế quản, và có những cái vị trí thì nó cũng đã xâm lấn cái niêm mạc phế quản bình thường và phá vỡ cái cấu trúc niêm mạc bình thường. Thì đặc điểm của tế bào u lên là những tế bào không bào tượng khá là rộng, xếp thành từng dải nên nhân hạt nhân thì rất là rõ, thì độ ác tính thì à, rõ rồi, xếp với lại không tế bào nhỏ cũng là phù hợp rồi. Đây cái niêm mạc phế quản bình thường, và phần u ở dưới đây cũng có một số chỗ gợi cái cấu trúc tuyến nhưng mà nó cũng không rõ ràng lắm, có thể đám thành một cái đám gợi cấu trúc tuyến nhưng không rõ ràng lắm. Và còn lượng hormone miễn dịch thì em ngược với TTF1 đây. Các tế bào u có thể dương tính trung bình thôi, còn đến yếu đến trung bình. Cũng có cái tế bào u dương tính, có tế bào u không dương tính, không phải là tất cả nhưng mà cũng có biểu hiện khá là nhiều, trên 50% tế bào u. Cái Narcin A thì đây có một số cái cấu trúc loạn tuyến thì lên Narcin A cũng khá là rõ, còn thành phần dày dạc hơn thì cũng lên mức độ yếu. Còn đây là cái P63 em nhuộm thì có cái nội chứng cũng rõ, cái TTF1 thì cái nội chứng chứng dương thì rõ, còn cái nội chứng thì nó lại không lên rõ. Còn cái B63 thì nội chứng khá là rõ ràng khi mà cái lớp đáy của cái niêm mạc phế quản bình thường, còn lên với B63. Còn thành phần u ở bên dưới đây cũng lên với B63 rất là rõ. Hiện tại thì ở khoa cái B40 thì hết nên là em dùng B63 thay thế. Thì toàn bộ là cái phần B63 bên dưới u đều dương tính. Đây cái B63 này, dương tính khá là mạnh. Và thấy hình thái nó cũng không rõ, những cái hình thái vị trí mà lên với B63 cũng không rõ về cấu trúc tuyến. IGA thì 3 cộng. Về CK56 và CK7 thì vừa mới nộp xong thì em cứ chụp ảnh cũng đều dương tính mạnh lan tỏa. Thì cái này xin là ý kiến của giáo sư với cả chỗ chị Hân, thì chị cũng gặp nhiều trường hợp như này chưa. Xin hết ạ. Yes. Please professor for some comment.
So this is a hard case, and I think it highlights the fact that, as we say, the tumors don't always read the books, and they don't always behave in the way that we would like them to, with regard to staining and other features. So I'll just go through a couple of your slides as well. I can get them to come up here. Working. There we go. So one of the things you mentioned was napsin. And napsin is an interesting stain because it can be quite patchy in some settings. And here we see just a few traces of cells that are positive. In the lung, we always have to be concerned about entrapment of normal elements. And so when we were looking, for example, at the B63 stain, which we'll come to here in a moment, here's a little bit more of this kind of weak positivity, and this looks like some of it's definitely in tumor cells. So that's usually associated with neoplasia, but here we also see some glandular elements that could be residual bronchial tissue. And so in the lung, you have to worry about entrapment of normal elements, both with regard to TTF1 staining and napsin staining on occasion. And here again, some of this could be entrapment of normal elements. I don't think so, This, I believe, is the P63 stain, P63, which is more hugely positive. But with P63 staining in the lung, I think we also run the risk of capturing some of the normal elements. And here you can see that in this portion of the biopsy. This is a very orderly array of P63 staining, which would indicate that we have a bronchial basal lamina sort of area that's staining with these normal elements. The other thing about P63 staining is that it's not entirely specific for squamous carcinomas. And in fact, we know in the salivary glands, for example, myoepithelial cells, or those that we see even in the breast, myoepithelial cells can stain positively with this marker. Now, in these other sites, there are tumors that have myoepithelial differentiation. And so that's a possibility that some of that is actually more towards the salivary type lesion that is developing here as well. So that also comes into our differential consideration. Is there any way that this could be a minor salivary gland of tracheobronchial origin that is producing a myoepithelial tumor, and then we have some trapped other elements from the lung or otherwise. So with that caveat, I think the fact that we do see bronchial epithelium here makes that a possibility because we have enough epithelium associated with this that there could have been pre-existent minor salivary glands. Okay, staining intensity. I think also is an important factor with some of these nuclear stains. This staining for TTF1 is a little bit on the weak side. And so I don't know how your control stain. Let's just see if we have more examples of this. But this is really quite weak stain. It's weaker than the P63, as you can see here. So that is another factor that I take into consideration, is how intense is the staining, and is it overwhelming to make me convinced it has to be TTF1 differentiations, or is it otherwise? I don't think here that we have a pattern of entrapment. This is pretty well most of the cells that show some of the staining. So these are tumor cells not entrapped normal lung tissue. And then we have this picture with the bronchial epithelium, this neoplasm. So what do we do in a situation where we don't have a definitive answer? Well, I think we have to call it a non-small cell carcinoma of uncertain histogenesis. Whether it's adeno or squamous. I don't think we would say it's squamous because that usually is sort of too divergent to differentiate and consider generally more clear cut rather than cells which are kind of ambiguous in between squamous and epithelial. But the fact that we have, both the napsin, the CTF1, and the P63, as well as you mentioned the CK56. I don't think I saw those stains, but that would also be, again, another consideration for squamous differentiation, ambiguous results. So I'm not a lesion pathologist, as you know. This is not my area that I work in every day, but as I think through the case that you've given us, I think that's where we would probably end up, is in reporting it as a high-grade carcinoma with ambiguous features, and then they would probably from there rely more on the molecular markers than on the immunohistochemical signs of differentiation. So I don't know, anybody else have some thoughts on that case? How you would handle it at K Hospital or at one of your other hospitals there?
Professor Hassel, can I ask you a question? How about the EGFR? It is, I found that it is true positive EGFR, and
Yes.
it's diffusely positive. And we will offer, uh, I I understand that it is mostly positive in adenocarcinoma, not in the squamous cell carcinoma. So can we um uh, can we give some criteria for diffusely positive with the EGFR and TTF1 is often positive in adenocarcinoma also, and the P63 is not specific for squamous cell carcinoma in most of the case, and especially in about the morphology, the tumor cells does not have the squamous differentiation. So can we can you uh, think think of adenocarcinoma not other than the squamous cell carcinoma in this case?
Yeah, so you're right. Those you have positive markers that have some degree of specificity, but
Yes.
to be quite frank, we don't have a lot of experience with EGFR to the same extent that we do with TTF1 and CK56, P63. And so the usual markers that we would use and that we have the most experience with are ambiguous. So there's some positive for squamous, there's some positive for adeno,
Yes.
and in that situation, I think you know that's definitely where I would do the molecular markers in this case to see where does the patient's molecular phenotype stand to indicate where the treatment should be. So yes, EGFR can indicate that maybe we should do the treatment with that specific marker. But I wouldn't rule out some of these other possibilities and so forth. So yeah, this is a case where knowing that there's that ambiguous findings, you could be justified in going ahead and treating as the most likely to be adenocarcinoma. But I think when you do that, you have to realize that there's a possibility that there's going to be some variation in this, and it may not respond in the same way that many other more conventional adenocarcinomas would respond to treatment. And so alerting the clinician to this situation, and then that will potentially encourage them, if they see poor response or something of that sort, to do either repeat biopsy or repeat testing for other possible treatment arms in this patient. I think this is one of our roles as pathologists, is to identify when cases really fit well in a diagnostic category and when they don't quite fit into that category. And then to communicate, I'm comfortable that this needs to be treated, and it'd be great to treat it as an adenocarcinoma, but I would be concerned if there was a recurrence or a treatment failure that could be because it's not a typical adenocarcinoma. It has some other morphologic and immunophenotypic findings that make it worth considering something else be undertaken to possibly treat it. So I think this is where your relationship with your oncologist is very valuable, and being really clear in your report, kind of what features lean one way and what features lean the other way.
Thank you, Professor. Yeah, I remember an article. It reported that in TTF1 immunohistochemical stain, if you find though it's small amount of true positive yeah, pattern, it can suggest you it could be uh, the AC of the lung. I know that. So
Yeah.
so it's very very difficult. Yes.
Yeah, this is a challenging case for that reason, because it doesn't fit quite perfectly as you would like it.
Yes.
And it's a significant enough reservation about it that your clinical colleague needs to know so that they can at least be aware or monitoring for any sort of treatment failure or poor response.
Thank you, Professor.
Great cases, Dr. Lin. Very good choices
Yes.
for discussion. You're grappling with really the hard problems that we have in pathology.
Mm. Very hard.
Do you prepare from the trip to Vietnam on April?
Yes. I'm working on my schedule right now so that I will be able to arrive in plenty of time and enjoy being with you for a few days.
Yeah. Please send me receipt of the plane ticket. Yeah.
Okay, I will do so.
Yeah,
Okay.
Professor. So, yeah, can you give us your